So today we are going to see how to read the blood test reports. Blood tests are very important, inevitable, common tool for diagnosis. It is not only meant for the modern medicine or allopathy, but for everyone, even for the therapist also, to understand and know the level of damage or the level of the health under various parameters, how it is. So we can use this excellent tool which will give us a complete idea about so many things that otherwise normally we will not be in a position to understand. Whether it is not only that no blood report, but also the scan reports of various natures, whether it is ultrasound or MRI or PET or CT or whatever it is. So that class we will have separate. In this session today, we are going to see only the common blood tests that are almost in 95% of the cases needed to be taken. So in this session,
ना विचलित हो गया। अब इधर उधर दौड़ रहा हूँ, फिर रहा हूँ, क्या करूँ क्या करूँ, इमोशंस जाग गए।
Sir, just started now.
just now started.
Thank you for Fadnavis sir.
Even
Those
I
who are
was also
there,
waiting,
not in
waiting.
the those who are not there in that common group, free TCM BUPS, free TCM group, you please join.
Yeah,
Because
sir, I have sent a request. I was not there in that group.
okay, we
Yeah.
will add there.
I was trying to call you, but your phone was busy.
Yeah, continue. So many other persons also were calling, including Fadnavis sir.
Yeah. Yeah.
Okay.
Okay.
So the common tests, almost in most of the cases, almost 95% of the cases, these are all the tests that are commonly taken to understand, identify the level of health. The tests are, one is the common one, which is CBC, complete blood count, or complete blood picture also. Some persons, they name it as complete blood picture or complete blood count. And then LFT is the liver function test. RFT is renal function test, that is about the kidneys. Then lipid profile. So wherever the involvement of heart is there, for diagnosing, lipid profile is inevitable. With regard to the hormones, thyroid hormone is the most common one, both for male and female. And for female, there are set of hormones which regulates their menstrual cycle and which determines the level of fertility. And not only the fertility, but also these hormones play a critical role throughout their life, even after the menopause, also on various ways and means. We will see all those things individually when we are seeing the hormones, that is gynecological hormones. In the gynecological hormones, we will see normally estrogen, progesterone, and then LH and FSH. FSH is follicle stimulating hormone. LH is luteinizing hormone. What is the role? How it is, from where it is secreted, how it is secreted, all those things we will see. And then we will have a complete urine examination in which what all the parameters that mainly indicate what condition in the body. So with this, almost we will get to know exactly what the level of health it is there with regard to the organs, with regard to the overall the health level. First, we will see about a CBP, that is complete blood count. The blood is having the components of both cell as well as non-cell items.
Recording in progress.
Blood has got two components. One, cells. Another one is non-cell item, that is serum. The cells have different categories. Red blood cell, white blood cell, and then thrombocytes or platelets. Besides this, they have got so many other items. Like proteins will be there, water will be there, all the nutrients, whatever it is there to be transported to the cell, from and to the cell. Everything will be there in the blood. We are concerned mainly with the cell items. In that, first we will see about red blood cell. If you want to understand about complete, normally what we do is that if at all we see something with regard to the red blood cell there, we will see only the hemoglobin. Other than that, there are so many other parameters. If you see in a report, I will show you a model report so that you will get some idea. Okay. The first one is about WBC. Afterwards, if you come, RBC, hemoglobin, PCV, MCV, MCH, MCHC. Almost 90-95% of us do see and understand only the hemoglobin part. And even if any increase, decrease, or whatever it is there in this, we will not normally even first understand, and we will not see. But individual items of these will give you a lot of clues. That is one of the major purpose for this session, wherein how to understand each and every parameter in the report and how to decipher that, what these reports do mention. With that, we can understand and formulate an appropriate treatment protocol for them. Hemoglobin is the one which carries the, which is present there in the RBC, red blood cell, which carries the oxygen, which exchanges the gas between the cell, and it carries to and fro from the lungs and the cells. If a person is having less of hemoglobin, we all know that is anemia. Rarely, the person may also, some persons may be having more of hemoglobin. That condition is called polycythemia. Polycythemia in case of RBC, in case of WBC, it is leukemia. Leukocytes are called as white blood cells. So before actually we get into the actual part to understand about the anemia, because this is almost 95% of the cases we will be coming across with the anemia. First, we will see what is PCV, packed cell volume. When a unit of blood, for example, for our calculation, we consider that we take around, say, 100 ml of blood. Then just put some chemical to make it, that is anticoagulant. Otherwise, it will become clot, right? So you put the anticoagulant. After that, centrifuge it. Centrifuging is putting into your tube, and you just, centrifugal pump will be there, and you need to just centrifuge, rotate on a very high RPM. So what happens if this is the tube? You are putting total, say, 100 ml. Of that, almost in a normal healthy individual, all the cell material will be deposited at the bottom. That is, heavy particles will be settled at the bottom. The light material will be floating afterwards. Of these heavy items, almost in a healthy person, 45 ml will be the red blood cells.
Sir, can you mute?
Mute all.
And above these red blood cells, we will have another thin layer, but volume wise, this will be very less. That is WBC. This portion is called packed cell volume. When the red blood cells are packed tightly. By
So
way
the
of,
heavier ones are the RBCs?
yes.
Okay.
So the RBCs will settle down and it will be closely, tightly packed. This volume, that packed cell volume, is called PCV or hematocrit.
Sir,
Yeah,
how is it different than ESR, sir?
that is entirely different. We will come afterwards.
I mean, process will be the same, no?
Sedimentation rate is, that is different. That is, there is no centrifugation there. Here, the sedimentation after the centrifugation, the packed volume of RBCs, that volume in a given volume of 100, on an average, in a healthy person, the RBCs will be around 45%. That means if you take 100 ml in a healthy person, it will be around 45 ml. Hypothetically, you take two cases where two persons are, you have taken the blood of two persons and you centrifuged it. Whatever the volume that is settled down, we calculated the volume. both are having, for example, hypothetically, 45 ml. When we count the number of RBCs, red blood cells, that make this 45 ml volume, that will give an idea about the size of individual cells. That means the 45 ml may be having any idea about how many in a 1 ml of blood, how many RBCs generally will be there in a healthy person? Any idea? It is around 5 million in 1 ml of blood. So we count how many number of red blood cells are there in this 1 unit of blood. That is called red blood count. That is RBC count, which is mentioned here. So how many number of cells? The shape of the RBCs are biconcave. Consider that this is the cross section you consider, because at the center it will be concave. So that it can bend and it can move through all even minute capillaries and all. And the entire cell, the red blood cell, will not contain RBC, hemoglobin. Hemoglobin is the ultimate content in the red blood cell. Hemoglobin is the essence or the juice of the red blood cell. The red blood cell is not having any nucleus, non-nucleated cell. So this hemoglobin only is the ultimate, say, area of interest. In case 1, the cells may, for example, here we consider that for calculation sake, the cells are somewhat bigger. On the other condition, the patient number 2, the cells are very small comparatively, but volume wise both are same. So what will happen in the first case, even though the volume is 45 ml, number will be, if normal is 5 million, because of the size, it will be less than 5 because the size is bigger. Right? When the size is bigger, automatically the volume will be same, but number will be less. For example, if you want to put, say, oranges in a small container, say 1 liter container, some water jug you consider, around 5 you can put, max 5 or 6. But if I ask you to put some amla, which is much smaller size compared to the oranges, you can put more than 25, 30 or even 50. Right? Volume is same, 1 liter. But if the cell sizes or if the individual item sizes are more, then number will come down. If size is less, number will be more. So in this hypothetical situation where the ml volume is same, that is 45, whereas the number of cells are lesser here because of the size, bigger one. Whereas in the second condition, the size is small, but good enough to make the same volume of 45 ml. That means it will be around 6 million. So the size of a individual red blood cell matters a lot, because the hemoglobin in each cell, when we calculate, there are certain aspects based on the size of the cell and based on the same size. Cell is also known as site, erythrocyte, leukocyte, thrombocyte, like that. Site means cell. One condition, normocytic. Another condition, macrocytic. Third condition, microcytic. That means site is cell. Based on the size of the RBCs, the cells are categorized into three. Like normocytic means size wise normal. Macrocytic means size is bigger. Microcyte is size is smaller. The size of the cell plays an important role, because the size plays a crucial role in accommodating the level of hemoglobin. Normally in a healthy person, healthy condition, the entire part of or the entire volume of the red blood cell will not contain full volume. To its full volume, the hemoglobin will not be there. So how much it will be there? Normally it is 1/3 of the volume. 1/3 volume of RBC only it can accommodate the hemoglobin. So already we have seen that a normal person will be having around 45 ml volume, right? In that, if you consider 1/3 volume of it is the hemoglobin. So how much it comes? 1/3 of 45 ml, how much?
15
15. General, right? That is normally 15. Here it is gram. 15 gram of hemoglobin in 45 ml of the red blood cell. The volume of the PCV or hematocrit is 45. This is the ideal one, or the average one, or the healthy person's average value. So if you calculate this MCV, that is mean corpuscular volume, that means in one cell what is the average volume that can accommodate the hemoglobin? The formula for that is the total volume of RBC divided by total number of RBC cells. Then we will get the mean. Mean is for one cell, what is the volume? Mean corpuscular volume. That means we have calculated around 0.45. That means if you take 1 ml, it is 0.45 ml of it divided by, in 1 ml we said around 5 million of red blood cells. That is the number. It is a count. So 0.45 divided by 5 million is equal to something like 90 into 10 to the power minus 15 liters. That is 10 to the power 15 is called, the liter wise it is femtoliter. Like how milliliter, deciliter, liter, all this. No, when it goes down, then it is femtoliter. That is 10 to the power of minus 15. So it gives the volume of individual RBC. Why we see this? To calculate what is the level, what is the size of it, and what is the level of hemoglobin that it can accommodate. So that is the ultimate objective of calculating this mean corpuscular volume. Then in that, what is the juicy part, or what is the actual that hemoglobin content? That is mean corpuscular hemoglobin. How much it is there? That is total hemoglobin divided by number of RBCs. That means we said only 1/3 of the volume of RBC can be the hemoglobin. It cannot be full. 100% it cannot occupy in the cell volume. So 1/3 of the cell volume of RBC, the hemoglobin will be there. That means in 45, we said 15. Correct, 15 gram. So we divide this 15 divided by 5 million. That is in 1 ml of blood. How much it comes? 30 picogram. How we calculated this femtoliter? The picogram is also like milligram, gram, like that. This is picogram. Then MCHC, in that actually what is the level of hemoglobin's concentration? We said, okay, what is the gram level? But percentage wise, what is the level of concentration? That is very important. So the total hemoglobin divided by total volume of RBC, that is hematocrit or packed cell volume. That is 15 divided by 0.45 in 1 ml. That means it makes to around 33% is the normal one. If you see in the report, they would have given something plus or minus 2 or 3 in the report in all these items. Say we say hemoglobin concentration 15. They may say for male it is around 13.5 to 17. To this side, to that side. For female, normally it will be a bit lesser than this. So all these values, the range they will give as the normal one. So if you see the report, Now you can understand.
The normal range differs from report to report.
Percent to percent, that will be normal range, not report to report. Most of the standard, no, some guys will
Lab.
be having. For
Yeah.
male, it will be around 13.5 to
Yes,
17. Normally they will say.
Exactly.
And 12.5 to say 16.5,
Exactly.
some ranges. But normal is 15. How this 15 is there? That we have seen how all these
Yeah,
reports they have
That's
calculated.
true.
So
Correct.
45. No, packed cell volume normally we said around 45.
Exactly.
Mean corpuscular here, if you see in this case, for example, 10.2.
Hmm.
Normally we'll say that 10.2 is less than 12. So the patient is anemic.
Anemia. Hmm.
But here what we need to see is that whether the number of RBCs are less.
Hmm.
What is the issue? Whether the number of RBCs are less or number is okay. In each cell, the hemoglobin concentration.
Hmm. Hmm.
That is the juicy part of each cell, whether that is lacking or
Where it is?
the size
Yeah.
of RBC.
Size. Yes.
So the size of the RBC, number of RBC, and the hemoglobin concentration in each RBC. These three are
Important.
very
Yes.
important to assess. We know anemia. Okay. Why anemia? If the number of RBCs are less, here only that all the diagnosis, that application of our knowledge comes. If the number of RBCs are less, what happens? Why it is less? Where the RBCs are being produced? They are produced in the bone marrow, right? Bone marrow is the site of blood production. That is hematopoiesis. That blood production is called hematopoiesis. In that, RBC production is erythropoiesis. Erythropoiesis means
Sir, in this,
production of RBC.
in this one, the number of RBC could differ from person to person and the size could differ, but then the hemoglobin in each and
Concentration
every
also
cell
could
will,
differ.
but
This
the
also will
hemoglobin is
differ.
always 1/3 of the RBC, correct? No
That
matter
is the
how
normal,
big the RBC.
normal,
Okay, no. So that also
normal.
that is also
Vary,
a very,
yes.
okay.
Based on the
Oh,
size of the cell, we have classified into three. That is, one is normal. That is normocytic. Correct? If the size is bigger, then we said macrocytic.
macrocytic.
Hmm.
If the size is small, that is microcytic.
But
Correct.
irrespective of normo
Depending
or
upon,
macro
wait,
or
I come.
huh.
Depending upon the concentration of hemoglobin in each cell, it need not have always that 15%, 1/3. It may go down or it may be appropriate. In certain cases, rarely it will be more also. So based on the concentration of hemoglobin, this also divided into three. That is, one is normochromic. Chroma is color. Normochromic means the hemoglobin concentration is appropriate around 1/3 of the total volume of the RBC, so it is okay. If this is more, of course, few rare cases, we will see what are the condition in which that will be more. Then it is hyperchromic. If it is less, then it is hypochromic. That means, if you see the cell, this is the normal cell, right? The cross section. Normally, the concentration will be more in the outer area and less in the center middle area where the depression is more, so that it can fold, twist and get into minor capillaries and go like that. In hyperchromic, it will be full. That means the central pallor will be very small. Only up to this, the pallor will be. Afterwards, full of pinkish, reddish. If it is normochromic, then it will be so normal. Then in hypochromic, the pallor will be only at the periphery. So the huge area is pale. There is no hemoglobin content, no juicy part. For that only we need to see what is the hemoglobin concentration. Before to that, just we will come to the first one, number of RBC. So if the erythropoiesis is not proper, it is whether due to the problem there in the bone marrow or inadequate supply of the nutrients needed for the erythropoiesis, like iron, vitamin B12 and so many other items. If they are less, or the hormone, there are certain hormones like erythropoietin which is secreted by the kidney. If the hemoglobin level is less in the blood, the oxygen saturation is not that much, the kidney senses that and it secretes one hormone which is called as erythropoietin. That is very, very important hormone that works on this bone marrow and enhances the speed of erythropoiesis. That's why if you see in CKD patients, they will be always anemic, because the kidney has lost its capacity to work properly, identify and trigger the erythropoiesis by way of secreting erythropoietin. So what the doctors normally allopath they will do, they will first give the erythropoietin injection form so that they can enhance, stimulate the bone marrow to produce more of RBC. So number of RBC, if it is less, and based on the pack volume, that is hematocrit, packed cell volume, the cell volume is okay, but only the cell sizes are small, then it is different. But volume itself is less. It is not 45. Normally we say around 45, not even 40. Here it is 33 in this condition for this patient.
In all abnormal blood,
So
bone marrow is also, no?
the production is less. The mean corpuscular volume, that individual RBC's volume, is also less. That what we calculated, it is around 90. That is also very less. Then mean corpuscular hemoglobin. We calculated that around 30 picogram.
Mm.
That is also less. So volume wise is also less. And overall production level is also less. So automatically the hemoglobin concentration, that means whether it is hyper, hypo, normo, that says the level of mean corpuscular hemoglobin concentration in that. That is also less. So with this we understand, we try to ask them, instead of just going with the hemoglobin part alone, you understand this and you identify whether it is the problem with regard to the bone marrow by way of producing
Yes.
required number
Bone-
of volume, required number of cells, and the size of the cell. If the size of the cell is small, again the concentration again will reduce.
Health of the bone marrow speaks a lot.
And it is contributed by various factors. If you see through, if you approach through the TCM, then we'll have to see, of course, bone marrow is there in the bone. Bone is controlled by kidney, water element.
Kidney, yes.
So we'll have to see there. And blood production, it is the combination of various G's, in which the liver is involved, the lung is involved, then heart is involved. So we'll
Spleen.
have to explore on all these areas. So what happens? When you understand actually what is the real problem there, instead of blindly just anemic, okay, you'll have to take vitamin or vitamin B12 or iron. Instead of telling that, you try to understand exactly what is what. Then we will come to the white blood cell part. White blood cells are the soldiers in the body. They fight the infections and it regulates the immunity of the entire body. There are two major types of WBCs. One is granulocytes, another one is agranulocyte, where the granulocytes are the granules visible there in the cytoplasm, whereas in agranulocyte it is not. Again, if you see in the report, normally we will see only the total count.
Yes. Count only.
If you see the count is more than 10,000, or normally it is 11,000, not even 10,000. It is 4 to 11 is the range. If it is more than 11,000, then we will say that there is a serious infection in the body. But need not be. If the infection is viral, you will not see even the numbers beyond 11,000. Even it will be less than that, but the patient will be having the viral infection, fever, severe fever, and other related problems or whatever it is there, that will be there. So if you come down into the differential count is the cell type wise. Each cell denotes individually, because each cell is having its own specific role to play. If you see the neutrophils will be, with regard to the number, it's a majority in the total white blood cell. They are the first responders for the bacterial infections, and they eat the phagocytic action. Phagocytic means they swallow the pathogens. They are bigger in size, neutrophils. So the percentage wise also, it is the predominant one in the total WBC count. Even it goes up to 70%. Followed by other items like lymphocytes, monocytes, then eosinophil, basophils. Say in the case of eosinophils, if any parasites infection are there, the eosinophils will be more. And in case of allergic reaction also, if a person is having chronic asthma, hay fever, allergic rhinitis, or allergy of any nature, eosinophils will be more. And even in case of autoimmune diseases, this eosinophils will be more. So when you see a person who is complaining with the rheumatoid arthritis symptoms and all, along with RA factors, when you take the CBC, you check for the eosinophils. There are so many autoimmune conditions. Autoimmunity is that our own blood cells, our own WBC is hitting our own body cells. That is because of two reasons. One, the normal other cells are mimicking like the antigens. Antigen is the foreign body, foreign cells, whether it is bacteria, virus, fungus, parasites, whatever it is. They call as antigens. Say our immune system, these WBCs, antibodies, they, instead of attacking these antigens, they attack our own cells, because these cells are mimicking or behaving or acting like the foreign cells. So that is one reason why it attacks. If more of toxin accumulation is there in particular areas, say uric acid accumulation more in the joints, you will be having more of our own immunity cells attacking the joints, which causes the RA. If such kind of action is there in the colon, then you will have Crohn's disease, Hashimoto's, so many diseases, psoriasis. So all the autoimmunity conditions, one is that the cells are mimicking like a foreign cell, or the intelligence of our own the antibodies to identify and attack the foreign and avoid our own cells, that is missing. So whoever comes, they will fire. That is a very bad condition. So in these two circumstances, the autoimmunity comes. So the eosinophils will be more in all the autoimmune conditions. In the case of basophils, they are very less in the WBC count. And they release the histamines and heparins during allergic response. So if the allergies are frequent, you will have to, along with the eosinophils, see the basophils also. And in case of inflammation, asthma, in all those conditions, you will have the basophils also more. With regard to the lymphocytes, which are next to neutrophils, with regard to the number, they are more. They have got 3 types of cells. One is B cell. Another one is T cell. Third one is natural killer cells. In case of B cell, they produce the antibodies. That is the immunity. With regard to the T cells, they kill the infected or the abnormal cells. That is like cancer cells and all. The natural killer cells are attacking the abnormal cell as well as the virus and all. The lymphocytes will be more in case of viral infection because of these natural killer cells. So if you test the blood, even if the total count, WBC count is less than 10,000 or 11,000, but if the lymphocytes are more, then the possibility of any viral infection or any kind of chronic inflammation, and if it is beyond certain level, 50, 60, 70% and all, then we should suspect of leukemia. Leukemia is the blood cancer. Like polycythemia, leukemia is polycythemia is for RBC and leukemia is for WBC. Excess production than the normal. Then the monocytes, monocytes are the largest cells with regard to the size. And it digests the dead cells and all. In case of chronic infections, you will see more of the monocytes. And in case of TB or in certain autoimmune conditions also, this will be elevated. So by seeing the individual count of cells, you can get to know what is the type of infection is going on, exactly what is happening there in the body.
Sir,
Yes.
even if the normal cells are like RBCs are more broken down, then also monocytes can be high.
I couldn't get your point.
If the RBCs are broken down more, like not more than normal,
Okay.
then
That
also the
means you are
monocytes will
telling
be high.
about hemolysis.
Yes, sir.
Okay.
So in that case also monocytes will be high.
Entirely different actually. There is no correlation between destruction of RBC and the monocytes there. Because the spleen is involved in the hemolysis or destruction of RBC.
Yes.
If you see, that is called a premature hemolysis. Normally around 120 days is the lifespan of one RBC. In case of premature, that is commonly seen in the thalassemia patients. Because thalassemia patients, they will not secrete any blood. Bone marrow is almost functionless there with regard to blood production. So frequently, once in a week or once in a fortnight or once in a month, depending upon their condition, body weight and other factors, they have to transfuse the blood. And normally, because of the frequency of transfusion and related issues and all, they tend to have two conditions. One is that the liver will be bigger, hepatomegaly, and also splenomegaly. That is, when it is swollen or bigger, then it is called megaly. Splenomegaly will be there. When the spleen size is bigger, again, it starts destroying more number of RBCs. So the cycle goes on. So the destruction is happening there. When the RBCs are broken down, they produce the byproduct called bilirubin, hemoglobin. This bilirubin is a toxic substance which is handled, detoxified by the liver and then excreted through the stools as well as the urine. A person may be having high bilirubin content in two cases. One, if the destruction is more than the normal, abnormal destruction of RBC is happening, that is premature hemolysis, or the liver is not in a position to effectively handle these bilirubin and detoxify them and send them out through urine and motion. If that is not properly handled in the liver because of liver issues, then the bilirubin will be more. And the bilirubin is also handled in the gut, urinobilinogen. We will see that in the urine report.
One question. One
Yes.
question that in case of blood group is decided by the bone marrow.
That is different, entirely different part. Let us not get.
Because in case of blood transplant, in case of bone marrow transplant, blood group changes.
Yes.
Of the person. Huh?
Bone marrow transplantation, blood group changes fully.
Acha.
Because the cells, the stem cells which are placed there in the marrow, they only produce.
Acha.
So entirely the stem cells are from the other donor.
Okay.
So entirely it will change.
Okay, just wanted to clarify. Thank you.
Welcome. So the third component in the blood is platelet. Platelet is mainly involved in blood clotting. Wherever the bleeding is there, bleeding of any nature, it combines with so many other enzymes and hormones and other things inside, like thrombin, prothrombin, vitamin K, so many other activities are getting inside, happening there, and it forms the web and plugs and closes the area of bleeding so that the blood loss is minimized or stopped. So if the platelet production is less, that is, the platelet is also known as thrombocytes. So if the production is less, then it is called penia. Thrombocytopenia is the condition where the production is less. Normally we see the dengue patients. Almost that is the only thing that we have heard, that if someone is having less platelet count, then we remember two things. One is dengue, another one is what leaf? Papaya leaf. Papaya leaf extracts. It's a commonly just goes with that. However, so what happens if low platelets are there, then the risk of bleeding, even small bruises inside, will create, especially the guys who are having the ulcer and all, they are more prone to internal bleeding. So if the person is anemic, you see in the other case, hemoglobin is less, the other things are also less. In certain cases, production, this, that, and all, everything, there is no other problem, but there is some kind of internal hemorrhage, due to which continuous blood loss is there. In such case also, the anemia will occur. And in case of ladies, menorrhagia. Menorrhagia is a condition where it is a heavy flow during the periods. So they will also have the anemic condition. The production is okay, the cells are okay, hemoglobin is okay, but heavy loss is there. So they are anemic. So if high platelets are there, then what will happen? The platelets are known for clotting. They are the clotting factors. So the risk of clotting, or because of this, the inflammation, the thickness will increase. Inflammation will come. So normally what, especially the stroke patients, because of the ischemic stroke. Ischemia is the blockage. Ischemic stroke means stroke because of blockage of the blood vessels, capillaries in the brain, which cause the stroke, infarct. Normally, these patients are given the blood thinners like aspirin, where the platelets will be diluted. So what are all the conditions that may lower the platelet count is one, the production itself is the problem. So the bone marrow is not in a position to produce. So the stem cells that produce these thrombocytes, they are to be treated. In case of autoimmune conditions also, like immune thrombocytopenic purpura is one of the condition, one of the disease that causes low production of platelet. And in case of infections, not only like dengue, but also the HIV. And in certain cases, hepatitis also leads to low production of thrombocytes. And certain medications like heparin induced, there also you will have lesser thrombocytes. And the liver disease, spleen disease, and some intravascular coagulation. These are all the causes of low platelet count. So these are all about the CBC overall. Then comes liver function test. Liver is another very important organ. There are certain good aspects about the liver, there are certain bad aspects about the liver. Good aspect is that even if the liver is almost destroyed 80-90%, it can regenerate. That has the capacity. And the bad thing is that up to that 90%, it will not show any symptom. When the symptoms come, it will be at advanced level. And the liver governs the almost, it's like a chemical factory in the body that regulates various mechanisms. So in the liver function test, we will have the tests like the components will be, first bilirubin will be there. As already we have seen, the hemoglobin, when it is broken down, the bilirubin is a byproduct of that. In case of, there are two categories in the bilirubin. One is direct, another one is indirect. If you see more of indirect, then you need to suspect mainly the hemolysis. You need to check the spleen for any splenomegaly, so that premature hemolysis is happening. And certain conditions like Gilbert syndrome also, you will have indirect bilirubin more. In case of direct bilirubin, it is because of the liver. Hepatocellular disease, hepatic, hepato means liver. Hepatocytes, hepatocellular disease. Then cholestasis. And both, if both direct and indirect, both are more, then it is a severe, serious condition, maybe due to hepatitis, or it is a worst scenario called a cirrhosis, which is irreversible. So bilirubin gives an idea, first look. Then if you see alkaline phosphatase, ALP, this enzyme is found in the bile ducts, bones, and also intestines. So if any biliary obstructions are there or bone diseases are there, in certain cases pregnancy induced also, this ALP will be more. And if GGT is also there, gamma GT, we'll see in next page what it is. If that is also more, then it is the problem, severe problem with the liver only. So we need to ask whether the person is alcoholic. If it is non-alcoholic, we need to see what are all the life cycle food habits and other things, and what causes the liver damage. And we need to accordingly treat that. Then another two common aspects with regard to the liver function test is SGOT and SGPT. Normally they say OTPT and OTPT ratio. That SGOT is found in the liver, heart and muscles, kidney and brains, general one. So it is not only related to the liver, but the damage in any muscle. For example, if a guy who is workaholic, he has done heavy workouts in the gym and all, then if you check, the SGOT may be high. The liver damage, or in case of heart damage also, the OT will be high. In case of PT, it is mainly related to the liver, like hepatitis or non-alcoholic fatty liver disease, that is NAFLD. So it is more specific to the liver than the SGOT.
Sir, in ALP, intestine is written. So, in what condition of intestine the ALP will be high?
There are so many conditions. Let us not get into all the details of the diseases.
Okay, sir.
Then, because we have to cover a lot of other things up to gynecology, urine, so many other, half of it is to be covered now, more than 1 hour. With regard to GGT, that is gamma GT, it is a biliary enzyme involved in glutathione metabolism. Any biliary tract obstruction or chronic alcohol not use, it is abuse, liver damage. So this helps to differentiate between the bone and the liver, the origination. SGOT, PT is there and ALP is also there. But if GGT is more, then we can get to know. We can narrow down. Then we have total protein. There are two types of protein. One is albumin, another one is globulin. These are synthesized by the liver and maintains the oncotic pressure is the osmotic pressure inside that cellular pressure. So in chronic liver diseases or nephrotic syndrome or malnutrition, this albumin will be erratic. And AG, albumin and globulin ratio, the normal range is up to 2. And SGOT, SGPT ratio should be less than 1. If it is more, then the problem is there. That means OT is more, PT is less. The third test is renal function test or kidney function test, which normally in the reports you will get to see the urea, creatinine and uric acid. And if you feel that creatinine especially is more and uric acid is along with urea beyond the level, it is much more than, instead of 35 it goes to 130, 100 plus, 200 plus, then you need to suspect and ask for the EGFR, that is estimated glomerular filtration rate, which says what is the level of the filtration capacity of the kidney, glomerules or the individual units in the kidney that filters the blood, takes the urine out. So urea is the waste product formed in the liver from the breakdown of the protein. So if the urea is more, ask the person what is the level of intake of protein. If he regularly takes heavy non-veg items and he also works out more immediately after the physical activities and all, if you check, normally the urea will be more. So you should not immediately jump into the conclusion that your urea is more, so you are having some renal issues. So it is a general indicator of the kidney function and also level of hydration level in the body and the protein metabolism, how the protein is handled there in the body. And the uric acid is the byproduct of purine metabolism. If it is more, you will have the problems like gout or kidney stones, and in severe cases, it causes renal dysfunction or kidney failure. The creatinine is a common, the parameter, the key parameter that informs about the health of the kidney, or we can assess whether the kidney is failing or not. Normally around up to 1.3 is the ratio, the value. If it crosses 1.5, then we need to be on high alert. If it crosses 2, then automatically in some stage of CKD, that is chronic kidney disease or towards the kidney failure. So the creatinine is the waste product from the muscle metabolism and excreted by the kidneys. If this is more, then GFR will be less. Even there are certain other tests also there, like cystatin C. Cystatin C also we can check. Then blood urea nitrogen. It is blood urea in that nitrogen part alone. Then microalbuminuria. Microalbuminuria. Cystatin C. These are all the tests if you suspect based on the renal function test and also the urine. If you see, you suspect, then you ask for BUN, microalbuminuria, and cystatin C along with GFR to ascertain for any CKD. Normally it is, for a healthy person, it is 120 ml. And if it is less than 90, then the problem, 90 to 120 is the normal range. If it is less than 90, then the problem starts. There are almost 4 stages. If it goes below 15, it is failure, gone, FUD. 15, 15 to 30, 30 to 45, 45 to 60, 60 to 90. There are 4 stages. Depending upon the volume it filters. So this gives an idea, understanding wherever these values are more, creatinine is more, urea, uric acid is more, GFR is less, then definitely the patient will be having less of hemoglobin. And the pressure also will be erratic because the kidney produces renin, angiotensin kind of hormones which regulates the heart's function to maintain the pressure. So there also the problem will be there. Another thing, lipid profile normally in order to assess the heart related threats. Is there any possibility that the patient may have any heart related issues? This lipid profile is seen. In that there are 2 parameters that we will see. One is cholesterol, another one is triglycerides. Under the cholesterol, there are 2 aspects. One is high density, another one low density. Lipoprotein is the cholesterol. So high density lipoprotein, which is also known as the good cholesterol, because it removes the cholesterol from the arteries. It brings back the cholesterol from the body to the liver. And LDL is opposite. But however, LDL is not the culprit always. LDL is used in repairing activities of the blood vessels, or rather even the brain cell development. This is very much needed. So the high level of LDL leads to the formation of plaque. Plaque means what? It's smearing there, clogging. Why it is clogging? Why it is covering?
Because
For
the
example,
wear and
if
tear of the
the
artery.
wall, correct, the artery wall, if that elasticity is lost. It should be flexible, elastic. The blood vessels are to be so flexible, so elastic that if the more volume of blood passes through that, it has to expand and allow free flow of blood so that the pressure is maintained at the same level, even if the volume of flow is more. And if the volume of flow is not required that much, if it is very much he is in a parasympathetic mode, then that is at rest and recuperation, rest and digestive mode. The blood flow will be in the sleeping or lying down and all without any work, the blood flow will be less. At the time, it has to again narrow down so that the less volume of blood flowing inside at the same level of pressure. If this elasticity is lost, then when the occasion comes to make more volume of flow into the blood, then when it expands, the cracks happening inside. It becomes like a hose in the garden. So you just put more than mild cracks. In order to plug the cracks, the LDL comes there and smears over there. Smear over a period of time, it narrows down. Then finally, the plaques create a block. So here the problem is not the LDL or not the flakes. Why plaque comes? Because the vessels have lost the elasticity. We need to treat the vessel only. This is the symptom. The root cause is the cracks or the loss of elasticity of the blood vessels. If you address that, automatically there will not be any plaques forming inside. Okay. You come to the triglycerides. They are the energy reservoirs. And the risk for pancreatitis and metabolic syndromes and also cardiovascular disease. CVD is cardiovascular disease. So normally we can see high triglycerides in the case of diabetes and the obese patients and the alcohol abuse. Then we come to the thyroid profile. Thyroid is a hormone which regulates the entire metabolic rate in the body. If there are two conditions, if it is secreted more, it is hyperthyroidism. If it is less, then hypothyroidism. If it is normal, the entire metabolic activity will be normal. If a guy is lethargic, he is not a lazy guy. However, he is unable to perform the normal activity in the normal pace. Looks like lazy, or the metabolic rate, heart rate is slow, putting body mass more. All this intervenes with other hormonal pattern also in the body. Normally the thyroid, the persons will be having PCOD also in the case of ladies. So the ovarian hormones also will get impacted because of that. So it governs the entire metabolic rate in the body, and also it influences the body temperature. In the case of hyperthyroidism, more, that guy will be always so warm, restless, not in a position to sleep properly. And irrespective of the level of food that he consumes, he will be always thin because the metabolic rate is more. It burns out fast. Wearing out is very, very high. And just opposite of the hypothyroidism, where everything is slow. So the thyroid gland secretes T3 and T4. T3 is more functional. T4 is the one which is afterwards deiodized. This is thyroxine. This is triiodothyronine. That is the name, chemical name. So this T4 is converted into T3 and T3 is functional. Along with the thyroid hormones, we will have to see the thyroid stimulating hormone also in case of thyroid performance. Because if the thyroid glands are not in a position to produce adequate level of thyroxine, T3 and T4, then the signal goes to the hypothalamus and then it triggers pituitary and pituitary secretes TSH. So when you see the values of T3, T4 and TSH, if TSH is more and T3 and T4 are normal, that means the thyroid gland is not in a position to produce adequately of its own and it requires more push from the pituitary, the master gland. If TSH is more and there are certain conditions where T3 is normal and T4 is less, or T3 is less and T4 is normal, then certain categorization like primary hypothyroidism or subclinical hypothyroidism and all will come. So we need to check what is the level of, say, TSH is normal, but T3, T4 is less, or T4 is okay, T3 is less. Then you need to suspect the pituitary gland here, because it is not monitoring properly and it is not stimulating it. So we'll have to check the pituitary's level, function level. TSH is elevated. T3 is more, whereas T4 is normal. Then subclinical. So based on the range level, you'll have to check who is the culprit. Even in the reports and all, you can get to know, they would have given that. Just I will show you. Are you able to see this? TSH is normal, whereas T4 is more. And if this is low, then it is primary hypothyroidism. If this is normal, then subclinical. If free T4 is high, then it is hyper. In the hyperthyroidism, normally the TSH level will be low. Normally up to 5. Above 10 only, you need to normally will be advised to take any thyroxine, L-troxin or pyranol. Then comes the gynecological hormones. There are two types of hormones that are secreted from the pituitary gland and two from the ovaries. These four regulate the entire menstrual cycle and enables the fertility and the related almost the cycle of it. FSH is the one which stimulates the primordial follicles. Every girl at the time of birth, they will be having lakhs of the follicles in their ovaries, immature. And as they progress, the age progresses, and when they reach the puberty and all, the lakhs and all will come into thousands. And in a cycle, alternate ovaries will make one follicle to mature and then ovulate, get released into the uterus. So if you see the structure of the ovaries. This is the life cycle of a follicle. Initially, it is that is called the primordial follicle. With the action of FSH, follicle stimulating hormone, these follicles grow. As they grow, they produce the estrogen, and at the mid of the cycle, during the time, the follicle also almost develops into full Graafian follicle. Afterwards, the ovum is released. That is called ovulation. That is again triggered by LH, luteinizing hormone. Afterwards, the ovum has gone into the fallopian tube, anticipating for the sperm. Otherwise, gets into the uterus and it's gone. It dies. Whatever the items remaining there, corpus luteum, that is called corpus luteum, it produces progesterone. So in the ovary, estrogen is produced, and then progesterone also is produced, and both are regulated, triggered, and controlled by the pituitary gland by way of follicle stimulating hormone and luteinizing hormone. LH is luteinizing hormone. So what happens up to this ovulation? That is one phase. If you see, if a girl or lady is having a regular menstrual cycle with 28 days, once in 28 days, from the date of period, just go back into 14 days. That is the day of ovulation. So if you take FSH, FSH will be always more. This first phase is called luteal phase, follicular phase. Second one is luteal phase. That is after the ovulation. So at the time of ovulation, the LH will be more. Whereas FSH will be more like this. FSH will come down, LH will be more at the time of ovulation, because LH only triggers the ovulation. And estrogen, this period again, estrogen will be more. This the ovulation means estrogen will be more. Afterwards, estrogen will come down after the ovulation. And the progesterone, initially it will be less, and afterwards it will be more. That is, during the luteal phase, progesterone will be more. With this understanding, you please go through this now. So FSH is secreted by the anterior pituitary gland, and this stimulates the follicle development. So if FSH is lacking, then there will not be proper maturation of the follicles, and that will lead to the infertility. Promotes estrogen production by granulosa cells, that is there in the follicles. So if FSH is less, then that will lead to the ovarian failure, or in the menopause also the FSH will be very less. And in PCOD, PCOS condition, again, you will see that FSH and mainly the estrogen will be less. There are 3 types of estrogen. Estrogen is a collective term, E1, E2, E3, of which normally estrogen is known as E2, estradiol, estriol, estrol, estradiol. So during the fertility period, E2, estrogen, estradiol only need to be checked. So it is produced by the developing ovarian follicles, and this promotes the endometrial proliferation, so that the endometrium thickness is maintained so that it can receive the fertilized ovum to nurture into a baby. So in order to get that blastocyst or the fertilized ovum getting fixed into the uterus, it makes the way for that. The endometrial, that proliferation is thickening, growth. If period is not, the girl is not conceived, there is no fertilization of the egg, then this endometrial layer will be coming out as the period. And the next cycle again, FS and LH will create this endometrium. And this estrogen is involved in the vaginal health and also the bone metabolism. So it influences vitamin D and also calcium. So those who are having PCOD and all, they are prone to have this vitamin D and calcium deficiency. And after menopause and all, the osteoporosis conditions will be very much prevailing in such ladies. If you come to the LH, as we have seen, it is secreted from the pituitary. And this is the one which triggers the ovulation. And it maintains the corpus luteum after the ovulation, especially if the ovum is fertilized. Then the corpus luteum will be maintained there to produce more of progesterone, so that it can harness the growing fetus. So the progesterone is secreted in the ovary by the corpus luteum after the ovulation, and this prepares the endometrium for implanting, and this maintains the pregnancy until the placenta takes over. Afterwards, placenta will directly get connected to the uterus, and it takes the role of giving all the nutrition to and fro. And this also reduces the uterine contractility. Otherwise, what will happen? If the uterine contractility, if the uterus contracts, then abortion will happen. So this avoids. So in the case of luteal cyst or the pregnancy, this will be more. And if it is less in the case of anovulation and in the any defect in the luteal phase. So we'll have to check these 4 hormones in case of any gynecological related issues. The last one, we are going to see the complete urine examination. So normally there are two, one is spot urine, another one is 24 hours urine. Normally we will say if there is no culture and other things are required, that spot urine, go give and they will check. That is a spot urine in which we will check for the parameters like glucose, albumin, ketone, bile pigment. So glucose will be there in the case of diabetic patients, and ketone also in the case of ketoacidosis. Ketone bodies will be there, which is because of the fat metabolism. So albumin will be seen in the case of kidney failure cases. So if you see more of albumin, plus, double plus, triple plus and all, so it is a signal that the patient is a CKD guy. Bile pigment, if you see the urobilinogen about the liver. If you see any blood or RBC, then you need to suspect any tumor there in the kidneys. If it is there, you will have blood or RBCs, any infection, urinary tract infection and all. Even the pus cell or epithelial cell also will be there in the case of bacteria also. UTI, yeast and mucus will indicate any kind of infection. In addition to that, you will have the color, pH and other specific gravity and all. Not that much, no. We cannot say that important. It is important, but generally, these are all the items in which you can get the clues about what is the health and what is happening there inside the body. So with this, we have come to the end of this blood report reading. Almost with these reports, we can get to know about the complete health checkup of a person.
To see the glucose level, HbA1c and all the things that we'll see later on.
HbA1c in the case of diabetes, normally fasting and postprandial they will see, but HbA1c is the most authentic one because it gives the average of
3
3
months.
months, not a shorter duration for 3 months. So if it is more than 6.5, then we can say that it is fully diabetic. From 5.5 to 6.5, we can say it is pre-diabetic. So around 5.5 to 6, it's normally it is there with everyone. Less than 5, less than 5.5, it is very rare. Very few cases we do come across in the patient's population, but around 6, okay. So we need to advise them more on the diet and lifestyle. Pardon?
Sir, not you, sir.
Okay. So thank you very much for your patience hearing.
Right. Nice.
Any other doubt? Is this helpful?
Very nice, sir.
Thank you very much, sir. Any other doubt? Now you can ask.
Sir, about HDL and LDL ratio, sir, can you say anything?
HDL and LDL ratios. Normally, the HDL will be around less than 50 is okay. LDL around 150 is the normal range. In all the reports, you can get to see what is the normal range that is needed. So if you see the LDL is more than the HDL, what it denotes is that there is some vascular related issues or the capillary damage somewhere in the body. In order to address that, the LDL is more.
Sir, the volume of your voice is very low. Can't hear you.
My voice is very
Okay.
feeble.
No, sir, it's okay. You check
It's
at your
okay, sir.
end.
Fine.
It's okay.
Thank you. So the LDL, HDL ratio and all, if both are within the range, that's what immediately you should not jump into a conclusion that it is somewhat no more, then you will be having this problem, that problem. No. The level of two things. Normally we feel that if you take more of fat items, oily items, these and all will create more of cholesterol. Actually, it is not so. That is a myth. Almost 80% of the cholesterol in the body is produced by, any idea? Can someone say? Produced
Liver.
from?
Liver.
No, not the organ. Produced from what item?
What is your question, sir?
80% of the cholesterol is produced from the glucose only.
Acha.
And only 20% whatever the fat and protein that you take. So it is not the butter, it is the bread which is the culprit. So if you feel that I am taking oily food, taking more of ghee, oil, so I'll be prone to have excess cholesterol. No. If you are diabetic, definitely you will be having more of cholesterol because this is the culprit. That is one part. Second part is that the LDL mainly, that is triggered by any vascular related issues. First, you need to treat. Invariably put LU9 for all those patients. Invariably. What is LU9?
Blood meeting point, influential.
That is the commanding point for blood vessels.
Blood vessels.
Okay, any other doubt? With regard to the
Sir, one more doubt.
gynecological things, if normally you see the estrogen level is less, so the progesterone will be more. When the progesterone is more, then the male attributes will be increased in ladies. That only will create that facial hairs, coarse voice, all those things. So the precursor for production of estrogen is testosterone only. From the testosterone only, estrogen is produced by the theca cells in the developing ovaries, follicles.
Sir, I have one question, sir.
Yeah.
Sir, usually we take Doppler studies for varicose veins, diagnosing those things. Can we, any blood test can diagnose varicose veins?
For varicose vein, there is no blood, no related test that can indicate, because it is the physical problem there. The stagnation of blood, which is not moving upward properly, which leads to the stasis there, and which creates that web. So Doppler is the one which says what is the level of that vasculature. Is there any DVT kind of a thing which blocks there, deep vein thrombosis, or that valves which involved in holding that is not properly holding it, so that it is drooping down towards the gravity pull. So for that only Doppler is a blood test and all. For varicose vein, to my knowledge, no.
Next time we'll see ECG, how to read the ECG also. ECG and all this thing. Next time, some other day.
Very complicated unless you have the basic idea about
Yeah.
entire anatomy and physiology of heart. Then whatever we say will, because unless you know the nodes, SV node, AV node and all.
Yeah.
You don't know what actually the node, where it goes,
Acha.
how the electric symbol is carried down. So accordingly, the wave also, P, Q, R, S, T.
Yes.
So if P is this level
Yeah.
and P to T up to this level, then exactly in the heart which area, whether it is at the AV node or SV node, or it is in the his, no, fibers.
Bundle of
Is
his.
having all those things, you will not be in a position to correlate.
Okay.
Even that was the question 2-3 times when I attended this the quiz conducted by Netflix.
Acha.
On that came. I came around 9th in the state.
Okay. Very good.
Thank you.